I think let us start. Let us start with the session. One second, I'll just admit one more. Yeah. So I don't know who's put this admit thing. I wanted anybody to be admitted actually. So next time I will remove this from the feature. Okay, so let us start with the terminology for neuroendocrine. Neuro means that it can be stimulated by the nerves. Endocrine because it can release hormones. So I will go through a few basics right at the beginning. You may actually know it, but I know there are different levels of students. There are first year DNB students or third year surgical, radiation, medical. So I know there is a mix. So it's very important that, you know, we understand the basics, which you will never forget for life then. And there is a bit of complexity involved in the treatment of neuroendocrine tumors. So after these two sessions, I want you to feel completely confident that when you see this patient in the clinic, you are absolutely fine in treating them. So the nomenclature in pathology, you will hear this a lot: differentiation, well, moderate, or poor. Grade, I think, again, we have this in all cancers: low, intermediate, and high. It means different in different cancers, but we all know poorly differentiated high grade patients are where the proliferative index is high, and the prognosis is relatively poor compared to other patients. Neuroendocrine tumors are also defined by the site that they originate from: lung carcinoids, you would have heard, thymic, gastric, pancreas, small intestine. That is the duodenum, jejunum, and ileum. So the jejunum and ileal carcinoids are quite common, and all of these are labeled as gastroenteropancreatic carcinoids. And this is what we will discuss today. Then you have appendix, colon, rectum, ovary, cervix, and others as well. And you also define them by the embryologic origin of as well, by foregut, midgut, or hindgut. And they're also described in various clinical trials as functioning versus non-functioning. Functioning means that they produce certain endocrine hormones which lead to symptoms. Also, they are described by the cell of origin, which could be insulinoma, glucagonoma, VIPoma. And over the years, actually in Tata Hospital itself, I've seen patients with insulinoma and VIPoma, and we can discuss them in detail down the line. Certain abbreviations are very important. Now, neuroendocrine tumor, neuroendocrine neoplasia is the term actually which is the current terminology that we use. Then you have neuroendocrine carcinoma, 5-hydroxyindole acetic acid. So midgut are serotonin producing tumors, and you have a drug actually telorostat which works against symptoms relating to high serotonin, which leads to diarrhea. So again, if you have a midgut tumor, doing a 24-hour urinary 5-HIAA is very important. And I'll just try and see how I let in some more participants. Yeah. So PRRT again is peptide radio receptor nucleide therapy. Long-acting repeatable LAR octreotide, you will hear a lot while I'm talking. So LAR just means that it's not short-acting, it's a long-acting hormone therapy that we are giving. Ki67, again, in breast cancer, we talk about it, but in breast cancer, it is not as standardized as it is in neuroendocrine neoplasms. Again, both of these Ki67 mitotic index, again, are about how fast the cancer cells are dividing. SSTR is the somatostatin receptor, and CGA is chromogranin A. So, like I said, they're no longer rare. They are the second most common GI malignancy. So we really need to know everything about this. And they have a long disease course. So you can hold all the treatments that I'm going to discuss today. Now, it doesn't matter whether you're doing your surgery, radiation, or medical. It's very important because quite a few of us will go not practice in major big centers in cities. We may go into small towns and practice. So it's very important to know what are the treatment modalities that are available. And there are some treatment modalities that you can commence the patient on as well. They have a long disease course. So all the treatment that I'm going to discuss today, most of the patients end up receiving all of them or some of them. So how to sequence these treatment options is very important. When to use what and when not to use what. When to treat and not to treat. So neuroendocrine carcinomas or neuroendocrine neoplasms are the only tumors where you have to think whether the patient really needs treatment, because watch and wait and observation is also a very good option for some patients. MDT, again, you're all cancer specialists. You're going to be a future oncologist. So MDT approach is very important. And you will hear me talk about a lot about midgut neuroendocrine neoplasms and also pancreatic neoplasms. A lot of the data is extrapolable between pancreas and midgut, as you will see. There are some drugs which act more in pancreas than midgut and the other way around. All of you should go on PubMed and look at these guidelines: ESMO, NCCN, ENET, UKNet, North American Neuroendocrine Tumor, the Spanish, and we also have the Indian Council of Medical Research guidelines, which is going to be published in the next issue of IJMPO, which I co-chair the committee with Professor Sri Khande from Tata Hospital, and we finished the guidelines a few months ago. So as you can see, the incidence is rising. We've already talked about this. This is a very important slide. Basically, this is from the SEER, from the American database. We don't have Indian data. The Indian data is being generated. In fact, we've published on the Asia Pacific Neuroendocrine Tumor Registry from Tata Hospital, which Dr. Jagannath led for whole of Asia Pacific. So what you can see from this slide is there are certain cancers which are better treated in tertiary centers. So the median survival of patients with metastatic tumors, if they were treated at centers of excellence, was 3 times higher than the survival of patients in the SEER database. So, I mean, like I'm from the NHS National Health Service, which has Universal Health Coverage UK background, where you have ENET's European Neuroendocrine Tumor designated centers of excellence. And the reason they have been made is because we know that the survival and the outcomes of patients is better if they are discussed in these centers. Now, understanding the pathology is very, very important for neuroendocrine. So it started from 1980s. The Ki67 came in as a prognostic marker in pancreatic nets. Then we labeled them as, so we no longer use the term carcinoid, which used to be used earlier. The terminology to use now is neuroendocrine neoplasm. And I would suggest that when you read through the guidelines, you will read the history about the WHO classification. So neuroendocrine neoplasms can be a tumor or a carcinoma. Very important that every patient has a Ki67 at the mitotic count. And quite often, I am a big fan of second opinions, especially in neuroendocrine, because we know that the Ki67 is going to drive the patient's treatment. Very important, don't hesitate in asking for a second opinion from an expert who sees more of neuroendocrine cancers than your pathologist, who may be seeing all types of cancers. And so I feel, our job is to do the best for the patient. And for that, if we have to take 10 opinions, we should. 2 heads are always better than 1. So immunohistochemistry, what is diagnostic or pathognomonic is they are positive for chromogranin A, synaptophysin, and CD56. In blood, we would do serum chromogranin A. Now, the thing to remember with when you send a patient to have a serum chromogranin A is to check that they are not on PPIs, because you'll have a false positive result. So you have to stop the proton pump inhibitors like lansoprazole or omeprazole or pantoprazole at least 10 to 14 days before, and it should be done fasting. The levels should be done fasting. 24-hour urine 5-HIAA is also important, usually raised in midgut tumors. But I do it as a baseline in most patients with neuroendocrine, because it then, like you do CEA levels, CA 19.9 levels in other GI cancers, it helps you follow up the patient better, because doing frequent scans is not right, especially when you've operated on the patient and you want something to follow up the patient. Specifically, in some tumors, you may want to do insulin, gastrin, or other hormone levels as well. Again, circulating biomarkers, chromogranin A is very important, and it has a prognostic value as well. So higher the value, the worse are the outcomes. Now, this is a very important slide. Now, WHO classification, I have not put the earlier ones on. You have WHO 2010 classification, and then on the left-hand side, you have the 2017 WHO. So please mute yourself if your microphone is on. So you have the 2017. So now you have well differentiated and poorly differentiated. So the first three columns are 2010 and the next three columns are 2017. I'm not going to discuss the bottom one, which we used to call as mixed adeno neuroendocrine carcinoma. It is now relabeled as mixed neuroendocrine, which is, you have the neuroendocrine element, non-neuroendocrine neoplasm. What do you mean by non-neuroendocrine? Is we mean adenocarcinoma or acinar carcinoma or ductal carcinoma or squamous cell carcinoma. So now you will see a lot of these reports which come with, say, rectal carcinoma with adenocarcinoma. You'll have squamous cell carcinoma with neuroendocrine differentiation. You may have a cholangiocarcinoma or an HCC with similar terminology. So they are now relabeled as NEN. And anything that is more than 30% drives the treatment for that. So if you have a patient who has more than 30% of neuroendocrine element, then that will drive the treatment. But if you have more than 30% of squamous element in that, then the squame will drive the treatment. This is a separate lecture on itself. So I will just leave it that this is the new terminology which we should know about. We no longer call them MANEC, we call them NEN. So now coming on to well differentiated. So high Ki67 does not mean it is high grade. So that is something which is new. So well differentiated grade 1 used to be Ki67 less than 2%. Now it is less than 3%. And for pancreas cancer, Professor Guido Rindi has done the most work in, and fortunate to spend some time with him and talk to him as well. And quite a few other NET specialists feel, NET pathologists feel that for pancreas, less than 5% is also fine. Grade 2 is 3 to 20%, same as before. But in well differentiated now, there is a new category, neuroendocrine tumor, which is grade 3. So which is more than 20% Ki67, and the mitotic index goes hand in hand as well. Poorly differentiated neuroendocrine neoplasms will always be grade 3, and they are called as neuroendocrine carcinoma. Could be small cell or large cell type. And the Ki67 is always more than 20%. So I think this is important. I hope this is clear. And this has been shown for as impacting outcomes as well. You have this type A where you have a well differentiated grade 3 neuroendocrine tumor with a Ki67 which is more than 20%. So it's but less than 55%. Type B is a carcinoma which has a Ki67 less than 55%, and type C is more than 55. And as you can see, that type A, B, and C, type C has the worst outcomes. And this also has a clinical implication for us, because patients who have are poorly differentiated, have a Ki67 less than 55%, they respond better to capecitabine temozolomide based chemotherapy. They do not respond well to platinum based chemotherapy. If the Ki-67 is more than 55%, they are very likely to respond to platinum-based chemotherapy. So it has a treatment implication as well. Both, anything more than 20% is very likely to be FDG avid, but for negative for the somatostatin receptor imaging, which I'll just talk about in a second. So you have for staging, so we've done the diagnosis now, where we've done so diagnosis is all about blood and pathology, biochemical diagnosis and pathological diagnosis. Now we'll come to the staging. Staging can be anatomic and functional. Anatomic, you have CT scans, EUS and MRI. Again, I will not go into details about that. As far as functional imaging is concerned, whichever city or town you are in India, you may not have a PET scan, but you may have a nuclear medicine department which is quite close. So if you have a PET scan department within nuclear medicine, if you have PET scan, the patient should have a gallium dotatate PET scan. If you do not have a PET scan department, then you may have a gamma camera where you will be able to do a high-neck tox PET scan, because what that will show you is whether the patient has a somatostatin receptor expressing tumor. Because even though the Ki-67 may be low, the patient may be somatostatin receptor negative, it is very important for us to know right at baseline whether that is the case. So again, all of these scans are very important. Within the same patient, you may have a DOTA-TATE or a high-neck tox scan, which is positive, and you may have an FDG PET scan also, which is positive. And if you read these papers, I've written all the papers at the bottom of each slide, so you can read those papers as well. Or if you want those papers, I'm very happy to email them to you as well. FDG avidity is usually synonymous with aggressive, poorly differentiated tumors. And DOTA avidity is usually synonymous with a well-differentiated or an intermediate differentiated tumors. And a patient can have both. So you may have a patient with a rectal cancer with liver mets, where the rectal cancer may be grade 1, but the liver mets may be grade 3. And it's not possible to biopsy every area. So my practice is that in each new patient, I try and do both, because it helps me treat the patient better, and I'll come to that why. It is very strongly prognostic above Ki-67 stage and chromogranin, though it has not been validated prospectively in clinical trials. So, this is the commonest presentation that we see. Yesterday itself, I was talking to Dr. Sanjeev, and then I had a call from a colleague friend in Trivandrum, a very similar case. The patient had an appendicectomy, and then you find on the specimen that the patient has a neuroendocrine tumor. And again, very, very important, you have to look at the margin, you have to have it reviewed to see whether it is actually an adenocarcinoma or really a neuroendocrine tumor or a carcinoma, to see whether the patient will need a completion right hemicolectomy or needs other scans as well. So this is the common presentation that I have seen, that patients present with obstruction, undergo a emergency hemicolectomy or any colon surgery or even a jejunal surgery. And the histology then shows, the patient has a neuroendocrine carcinoma, high Ki-67, you do imaging and you find the liver is studded with metastasis. So why, and a lot of times, patient goes for an executive health checkup, and the ultrasound shows that the liver is studded with metastasis. And this is actually quite common, that patients do go for a health checkup and they have liver metastasis. Sorry, I'm just trying to get. So why is finding the primary important, whether the primary is in midgut or pancreas? It's important because there are some studies, even though they're not randomized, there are some studies to show that if the primary is resected, then the patients tend to have a better outcome. Or it's possible that if the primary is in the midgut or jejunum or duodenum, not much area to grow, then patients may need a resection and may present with obstruction. And we know that it's better to plan elective surgery than emergency surgery. So this paper was very good in trying to find out the primary with these simple immunohistochemistry markers with CDX2, PAC6, islet-1 is the tier 1, and then you go on to the tier 2 markers, and there was 90% accuracy in finding the primary in pancreas and midgut. So I'll now come on to the somatostatin receptors, which is again 80% of most neuroendocrine neoplasms will express the somatostatin receptor 2. And these are the various types of NENs which show the level that they are expressed. But most of the drugs that we have target the somatostatin receptor 2. This is the first staging. So that's why we do the Hynek tox scan and the DOTA scan, which actually look out for these receptors. It's a staging modality, but also has treatment implications like PRRT, which we will talk about if it is positive. Again, this is just a slide to show that different types of pancreatic neuroendocrine tumors will produce different hormones and will have a different presentation. So for a VIPoma patient, they will likely to present with diarrhea, low blood glucose, high blood glucose, if it's an insulinoma or a glucagonoma. So the likelihood insulinoma is commoner than gastrinoma, glucagonoma, and so on. Very briefly, just one slide on MEN, multiple endocrine neoplasia type 1. It's the 3 Ps, parathyroid, pituitary, and pancreas. And these are so if you have a patient who has a family history, or if presents with a pancreatic neuroendocrine, I think it's very important to do a simple calcium level, blood glucose level, which will actually show you whether there is a possibility of another tumor as well. And then you can go down and do the other levels of tests. I will not go into role of early surgery or for pancreas, because the risk of developing pancreatic cancer is very high. Most insulinomas, let's say, are benign, but there is a possibility that some of them may turn into cancer. So there are guidelines which, if you are surgical, you must read them. That if so, ma'am, which is better, Ki67 or mitotic index? So I think both are equally good. Most of us tend to follow up Ki67. And there are guidelines, and there's debate also whether you should or should not operate. And there are some studies which show if the tumor is just less than 2 centimeter in the pancreas, one can observe. But if it is more than 2 centimeter, then one has undertaken. It is major surgery and a lot of implications for the patient with using creon, insulin, and other things. So I think one has to think very carefully before you plan the surgery. You can also do, if it's a small tumor, do enucleation of the tumor as well. So now let us come to the second part of the talk. So I'll talk for another 10 minutes and then we'll have questions. So whatever is remaining in the talk, we'll do next Saturday at 6 p.m. So we talked about pathology drives the treatment. And I would also like one of you to present a case next week so that we can discuss the complexities at that time as well. So tumor stage, yes, it decides treatment because obviously if it's a solitary pancreatic tumor, you would go for surgery. The DOTA scan decides the treatment, the intensity and the homogeneity of the involvement. Site of tumor is very important. Also, a very important question when you have a patient sitting in front of you is whether the patient has liver-limited disease, which we do in colorectal cancer, because we know the 5-year survival can be as high as 40% or even higher in some patients. So very important to know, because you can, even in neuroendocrine, think about liver-directed therapies if the patient has liver-limited disease. The extent of liver involvement is very important. Performance status. And the other thing, patient choice, it's always a shared decision-making between patients and us. it is very easy to say, I hear this a lot in India, that, oh, Indian patients just want us to tell them what the treatment is. I think if you start discussing with the patient, they will have an opinion and they will have a choice. And it's important that all of us as clinicians put all choices in front of the patients, and rather than making the decisions for them. Functioning versus non-functioning, very important, because if it's a functioning tumor, if a patient has hot flushes, diarrhea, then it's very important that we get on top of the symptoms first. And sometimes surgery is the only option to get on top of the symptoms. I'm just trying to admit somebody, sorry. Yeah. So availability of therapy now in US, I know PRRT we were very lucky in India that PRRT was available to us and has been available to us because of places like AIMS, Tata Hospital, and quite a few private centers as well. But in US, it was not available because it was not FDA approved. So I think the whole concept was started in Rotterdam in Netherlands, and so in Europe, it has been widely available. I have put here tempo of progression on serial scans. It's very, very important. So I had a patient who came in the clinic, had an executive health checkup. Liver was studied with the, so it's a highly vascular tumor. So it's most of the time we are able to say on CT scan and ultrasound that this is very likely to be a neuroendocrine. It almost looks white on the arterial enhancement. So, this patient came, liver function was completely normal. He was PS0, was exercising, was doing everything normally. This was when I was in Cambridge, and we had a neuroendocrine clinic running. I was quite surprised because my first instinct and my teaching has always been that, let us start the patient on chemotherapy or something. Liver involvement, bad prognosis, the patient is going to go off, is going to go into liver decompression quite soon. And then, we will not have the window of opportunity we talk about of treating. And then when I looked at his notes, he had been on follow-up for 1 year. He was, almost 1.5 years actually, because in the first year he was having 3 monthly scans. And then the frequency of scans was changed to 4 monthly. So even though the scan may look quite bad and scary, the patient had a low-grade neuroendocrine tumor with a Ki67 of less than 2% and had been just on watch and wait and observation. So I think this is very, very important for us in India because we are a resource-limited country. I would say 70 to 80% of our patients will not be able to afford the treatments that I'm going to discuss. When you start any of the targeted treatments I'm going to talk about, even though we have generics which are available, most of us cannot afford it. And the other downside is once you start, you can't stop. Whichever treatment it is, whether it's whatever we'll discuss now, all the targeted treatments, once you start on the treatment, you have to continue those treatments forever. Forever means till progression. Or they have intolerable toxicity. So very important that we keep this in mind for low grade, or even I think one of the patients that I have observed had a Ki67 of about 6% or 7% with a pancreatic neuroendocrine, and we observed the liver metastasis for quite some time. I can't remember how. And on serial scans, when the liver function starts getting affected, or you will see you're doing 3 monthly blood tests, you're doing 3 monthly scans, then that may be the time to discuss some treatment option. The goals of treatment, I think the most important is symptom control and quality of life. So what are you palliating? If a patient has liver mets and is completely asymptomatic, is playing golf and going to the gym, nothing. So might as well let him lead his life rather than come to the hospital every month for an injection, or even start on any other targeted treatment. The second goal is cytoreduction or tumor growth control. And of course, living longer is the most important thing that we want for our patients. These are the treatment options: surgery, liver-directed therapy, and watch and wait. So the top 3 I won't talk about because surgery, I may show some studies down the line which show that patients who do undergo surgery, even with metastatic disease, have a better outcome. Liver-directed therapy also I will touch on towards the end. And there is a lot of debate about whether you should do transarterial chemoembolization or just do transarterial embolization or just do radioembolization. So I will talk a little bit about that as well towards the end. These are the treatment options that are available to our patients today. And I think we all should know about them because they're easy to give. They're either hormone therapy or oral therapy. So somatostatin analogs are octreotide, lanreotide. Octreotide long-acting is easily available in India, and the dose is 30 milligram. It's given intramuscularly every 4 weeks. Then you have mTOR inhibitors, everolimus, and I'll talk about that. Neuroendocrine neoplasms are highly vascular. So, that's why anti-angiogenic treatment is quite important. So we have drugs like sunitinib and bevacizumab I will talk about. Cytotoxics, again, capecitabine, temozolomide, orally given, very easy to administer, very easily well tolerated if you get the dose right after a couple of cycles. And then you have cisplatin and etoposide for patients with high-grade neuroendocrine carcinomas. PRRT, you have yttrium-90 dotatate or lutetium dotatate, which is currently the standard of care because of a phase 2 study. And then you have tilotristat, which is mainly given, like I said, I won't discuss this because it is not available, but it can be imported for patients who need it for uncontrolled symptoms related to diarrhea, mainly with midgut tumors, which are high serotonin producing. So your thinking should be, when a patient comes to you, does the patient have a resectable primary? And does he have only liver-limited disease? If it's unresectable liver-limited disease, then you have liver-directed treatments, which we will talk about. We'll also talk about PRRT as downstaging prior to making unresectable disease resectable. So there's a lot of advancements that have happened, which hopefully helps us look after our patients better. You may have an unresectable primary and unresectable distant metastasis, and then you have all of these options. The evidence-based medical therapies summarized on these slides, and I'll talk about this. Octreotide in midgut tumors, you have the PROMID trial. I think if you're exam going, you must know at least the names of the trials and what the outcome was, what the progression-free survival, because it helps you talk to the patients better in the clinic as well, if you know the progression-free and the overall survival. So chat again, a patient has, I'm going to tackle the questions as they're coming along actually. A patient which has localized paresis grade 2, which is symptomatic but inoperable, then what are the options? So, the ESMO guidelines, I will come to PRRT. So we had a patient, I know we say that intermediate grade is less than 20%, but the ESMO, that is European Society of Medical Oncology guidelines, recommend that, you can give PRRT to patients with a Ki67 less than 30%. So grade 2, I assume that the Ki67 is less than 20%. So I would try and some form of downstaging mechanism. If the patient has a DOTA positive tumor, I would consider PRRT as an option because that will be the quickest way to downstage the cancer and then consider maybe surgery. Can we give somatostatin subcutaneous? Yes, you can. It is the short-acting one which is given subcutaneously. The long-acting one is given intramuscularly. So, okay. So these are the options we've talked about. Everolimus is the radiant story, which I'll talk about. You have sunitinib, and now we have pazopanib. It is not licensed yet, but it has shown good benefits. I'll just talk about it in 2 slides. So this just tells you about the binding of somatostatin and the various analogs which are available. So the somatostatin, which is, we give octreotide. I think if you're surgeons, you use octreotide a lot, or maybe not post-surgery, and also we use it in diarrhea as well. So how to decide whether to give PRRT or CAPTEM? So again, at the end of this talk, I think you should be able to decide whether you should give PRRT or CAPTEM. So my general rule is PRRT is cost effective, at least in India. If the patient has a resource constraint, I would prefer to give PRRT. In places like Tata Hospital, it is very, very reasonable, and Dr. Sandeep Basu does a great job. So, and at AIMS, Dr. Bal. So PRRT, if the patient has a DOTA scan which is positive, it's only 4 doses given at 6 to 8 week intervals, and I think it's a one-off thing. CAPTEM is again an option if you have a Ki 67 less than 55%. You can give it, and again, the symptoms, if you want a rapid response, I would consider PRRT actually. But you know, one doesn't exclude the other. So I will also talk about that you can give CAPTEM with PRRT if the patient also has FDG positive disease. So can we downstage the tumor by somatostatin analogs and then go for surgery for above a question? So as you can see, the downstaging by they do not cause that much downstaging. There's time to tumor progression is better. There is progression-free survival. Per se, if you look for shrinkage, that is not, I think I would, if you're looking for shrinkage, I would go for PRRT. So going to the next one. Slide, yeah, sorry. So if you can see, it can downstage in some, but it's very rare. It's about 10%. So you can try, but it's a very expensive. Every month you have to, patient has to spend 15, 20,000 with the generic one. The other one is almost 25 to 30,000 rupees. So in this slide, you can see it from 2006, 2007, there is excellent downstaging that has happened. But again, this is very rare. This is not the norm. PROMIT, I think I will discuss PROMIT and then we will stop, because otherwise I think it will be overload for you guys as well. And we'll maybe take some questions. One more question is there. Let me see. Is pancreatic primary always to be resected even if less than 2 centimeter? So it depends what the histology is. So like I said, there is debate. If you have in men, there is debate. But if it's not men, and let's say you have insulinoma or if it's symptomatic, yes, there is no doubt you have to resect. But even in others, you know, if I was the patient, I would want it taken out, because even if it's benign, there is a possibility it may turn malignant. So I would resect. The debate is in NEN1. The debate is not in patient presenting with a pancreatic tumor. You should undertake surgery even if it is 1 centimeter. So this was a phase 3 randomized in mid-gut treatment naive patients who were metastatic, well-differentiated neuroendocrine neoplasms. Primary endpoint was time to tumor progression, had octreotide 30 milligram once a month versus placebo. So as you can see, you know, even in the placebo arm, whether it's functioning or non-functioning tumor, you have a median time to tumor progression of 6 months, which is the take-home message for me. So you can observe these patients. So median time to tumor progression of 6 months is excellent, you know, and this is median. The range can be 2 years, 3 years as well. So significantly better, obviously, with the active treatment of octreotide. Time to tumor progression was 29 months in non-functioning, and so it works in both functioning and non-functioning. So these were the 2 trials actually for the medical oncologists. This is very important. Clarinet and PROMIT. Clarinet had lanreotide and Clarinet had JEPNETs. And that's why I was saying that even though the octreotide was only in mid-gut, we tend to use it in pancreatic tumors as well, because lanreotide is not available in India. And 70% in the PROMIT trial had the primary removed, while in Clarinet about 40% had the primary removed. And as you can see in this slide, This is comparison of Promid and Clarinet, both of them showing a significant increase in time to tumor progression or progression-free survival with the use of this. And it's about 14.3 months versus 6 months versus it's more with but the endpoint and the way that is measured is slightly different in both the studies. The subgroup analysis of Clarinet for midgut, when they looked at midgut and pancreatic NET, showed that the benefit that was coming was more so from the midgut neuroendocrine tumors. The hazard ratio was 0.35 here versus in pancreatic was 0.58. Dose escalation, it does help. So if you have a patient who has a lot of symptoms, I've had patients with flushing and diarrhea. So you can, it does, as you can see from this slide, that there is a decrease in 5-HIA in 23% patients. Chromogranin A goes down. Radiologic stable disease is there in almost 30% patients. Diarrhea, the number of patients where the diarrhea is improved is almost 62%. Flushing, abdominal pain, and wheezing, bronchoconstriction is helped in a quarter of the patients. This is the last study I will discuss. Is interferon is a drug which we've forgotten about, and I've used it a lot in my earlier days in myeloma patients. And the reason why we've forgotten about this is because it's quite a toxic drug. But pegylated interferon is quite well tolerated, and if you combine it with sandostatin, there is a significant delay in progression, and numerically the survival is also better. The reason why I wanted to put interferon is when I attended a class with Professor Kjell Oberg in Uppsala, he showed a few patients where, because sandostatin receptor is so important, so there is a small proportion of patients where if you give interferon, that can upregulate the somatostatin receptor. And when I was in Tata Hospital, I think with Sandeep Basu and Dr. Srikhande, we had one patient out of 5 or 6 patients that I gave pegylated interferon to, who was DOTA scan negative before and then became DOTA negative, became DOTA positive. So I think this is something we should keep in mind. So it's very important. So the take home for somatostatin, anti-proliferative effect is better in midgut. Observation is appropriate for asymptomatic patients. The hazard ratio is similar for octreotide and lanreotide. And I would select a somatostatin analog for Loki67. Volume of disease, again, you know, there is a lot of controversy. You can give it in high volume disease as well if the function of the organ is maintained. SRS positive, slow growing when you look at the tempo of progression on the scans. And midgut, but again, we tend to use it in pancreatic neuroendocrine neoplasms as well. It works both in functioning and non-functioning tumors. I think next week, Saturday, same time, we will discuss the targeted treatments. We'll discuss PRRT, surgery, and radioembolization and everything else. So I think I'm going to stop here now because, but if I've taken questions as they've come along, but you are most welcome to ask questions and unmute yourself if you'd like to. I'll just I'll stop sharing. Yeah. And next week, I'm happy to email you the slides if you want. So, you know, for your teaching, you can have access to all the slides. Just drop me an email. I've sent you on the chat my email. So just send me one new message. So considering tumor heterogeneity to be common in PNETs, should we both do? Yes, absolutely. Very good question. You must do both FDG PET and DOTA, gallium DOTA Tate PET in the patients. Because, you know, like we had, the patients I still treat with Dr. Basu if a patient has FDG PET and also DOTA positive, both positive, Then with PR, like, with rectal cancer, pancreatic cancer, with radiotherapy, you give capecitabine as a radiosensitizer. So with PRRT, then we are able to give capecitabine as a radiosensitizer, and you have a beautiful responses in patients. So I think it's important for us to see whether the patient will benefit from chemotherapy to do an FDG PET. And if the FDG PET is positive, then we should consider giving chemotherapy as well. So what is the role of wait and watch in patients with gastric, which are grade 1? Yeah. So, gastrinomas in pancreas. So most of them will present with gastric ulcers, and sometimes just treating them. So in the 90s, it was difficult to treat them, but giving ranitidine and proton pump inhibitor is good enough. And if it becomes problematic, as if they're part of the Zollinger-Ellison syndrome, we can talk about next week if you want, then, surgery may be needed. But they may just be managed with watch and wait, and maybe an annual endoscopy and a PPI if it's causing ulcers. In what cases can we do observation only in liver mets and PNET? I think, like I said, if it's grade 1 to early 2, and again, if it's grade 2, less than 20%, patient is well, asymptomatic, incidental finding, what we have to remember is every patient is different. So I've had grade 1 NETs where they have progressed on the 3-month scan and needed treatment, or they presented with sudden progression and needing a treatment. So if there is sudden rapid progression, or let's say we are following them up on 5-HIA or chromogranin and it doubles, I think I would like to rebiopsy again, because the reason is if it has become grade 3 and the Ki-67 is more than 55%, I would want to give them cisplatin etoposide. So I think if there is rapid progression, it is worth rebiopsying the area if it is easily possible. And the other thing is, with next generation sequencing now, with precision oncology, molecular oncology coming up, it is important that, if we are able to find a driver mutation, we should have tissue available at the time of biopsy. But currently, I only consider it when I've used up all the standard options. We should not do it out of a clinical trial.